Hello and welcome to a video on movement disorders. This is part of the Neurology chapter of Step 2 CK First Aid. So we're going to be talking about Huntington's disease, Parkinson's disease, and then a few other diseases related to movement. And then at the end we will be discussing a little bit about different tremors and how to distinguish between them. So we start off with Huntington's disease. And Huntington's disease is an autosomal dominant degenerative disorder, and it's caused by the excess of the trinucleotide CAG repeat. And the CAG repeat is found on the Huntington protein, just here, and this is on chromosome 4, and it's during spermatogenesis. And this protein becomes dysfunctional, it builds up in neurons, and it causes a glutamate exocytotoxicity via the NMDA receptor, and that will then cause degeneration of parts of the brain such as the cerebrum, but most commonly the striatum, including the caudate and the putamen. So this is the areas that are most affected in people with Huntington's disease. The types of neurons that are damaged are the GABA neurons and also the acetylcholine-based neurons, which causes a drop in GABA and acetylcholine, but an unopposed dopamine action and activity in the brain, and this excess dopamine or unbalanced dopamine will be causing motor symptoms such as chorea. Okay, this is the jerk-like uncontrolled movements of the body, but it also causes memory problems, so executive dysfunction, and then mood symptoms as well, such as irritability. Huntington's disease is slowly progressive, and only symptomatic treatments are available. There's no cure for it, and usually patients will have death within 10 to 20 years. So now looking at the history and physical examination, usually it's going to be seen in patients between 30 and 50 years of age, and you're usually going to see a family history indicative of anticipation. What's anticipation? This is where each successive generation has the disease worse off and earlier on, okay? But don't expect to see in a USMLE or another type of examination question, oh, the father had chorea and neuropsychological disturbance and dementia. Often they're going to hide it a little bit, and they're going to be misdiagnosed with something like a psychiatric condition, or even they might just say a family member committed suicide. Okay, so they're not always going to make it so obvious. But the way that you can remember this sort of triad of symptoms is the 3 M's: motor, memory, and mood symptoms. Okay. Also, just to note in questions, just this whole idea of anticipation. A patient usually needs a certain number of repeats in the CAG, in the Huntington protein, CAG repeats. So maybe a family member did not have enough repeats to actually cause a full penetrance of the disease, but then this case that you're looking at has enough repeats to cause the disease. So just bear that in mind, you actually need a certain number of repeats to actually cause the disease, okay? So let's have a little dive closer into the motor, memory, and mood symptoms. So the motor, we usually see hyperkinetic symptoms, especially early on in the disease. As I've said, chorea, hyperreflexia, urine incontinence because of increased kind of almost bladder spasticity, and hyperhidrosis as well. So these are symptoms such as like jerk-like movements of the arms, uncontrolled rhythmic movement of the arms. Later on in the disease, the patients do get almost Parkinsonian-like symptoms. So we do see hypokinetic symptoms later on. This can include rigidity, dystonia, bradykinesia, dysphagia, and dysarthria. Chorea, as I've already mentioned, refers to random, brief, and irregular involuntary movements. This could be in the face, the trunk, and the limbs that flow between muscle groups. It's not isolated to one muscle group. Early in the disease, chorea may manifest as restlessness or fidgeting with delayed saccades. So do look out for that as the presenting complaint. Now moving on to the memory. Of course, I did say that we have neuron exocytotoxicity. This can affect all kinds of neurons in the brain. We usually have things like cognitive impairment, so an executive dysfunction, and then also dementia. You're probably aware that acetylcholine is the key neurotransmitter for making and consolidating memories. So when we talk about Alzheimer's in the dementia unit, usually it's the acetylcholine-based nerves that are degraded in Alzheimer's. So in Huntington's disease, we also have acetylcholine-based neurons degrading, which can cause the dementia. And then finally, mood. So this is usually signs of irritability, depression, and disruption of relationships. And this is often one of the first signs and symptoms, so this can often precede the chorea and the motor symptoms. We can also have other psychiatric symptoms such as OCD, aggression, anxiety, paranoia, and even delusions and hallucinations, suicidality, and psychosis. In fact, a lot of patients with Huntington's disease do actually commit suicide, okay? And a lot of these signs and symptoms can be mistaken for substance abuse, so do be careful in STEMs not to get confused between the two. Now moving on to diagnosis, the diagnosis is going to be clinical. You're going to be looking for the motor, memory, and mood symptoms. You don't have to have all of them, but you're going to be looking out for them. And then you should also look out for a family history, and you've got to look for this idea of anticipation. And misdiagnosed parents, grandparents with psychiatric conditions and suicide will count as that family history, okay? And as I've mentioned before, anticipation is this increase in CAG repeats in the Huntington protein throughout successive generations, which then means the patient will have an earlier onset or a more severe disease. Test creators may actually try and obscure these family history details by either making the patient an adopted child or somebody who maybe just didn't know their parents. Genetic confirmation, So the test creators usually obscure the details of the question by making the children adopted, but as I mentioned before, CAG trinucleotide repeats, we usually need more than 36 or more repeats in the gene to actually cause penetrance, full penetrance. So the parents might not have had Huntington's because they didn't have 36 repeats. Maybe they only had 33, 34, and they didn't have full penetrance and they didn't get Huntington's disease. Whereas the successive generation may have had that anticipation, may have had more repeats, and may have got 36, so will have had full penetrance of the disease. So just look out for that. It's not a be-all and end-all. So if you see a sort of scenario where the parent don't have Huntington's, do look out for whether that patient is adopted, and it could be that the CAG repeats were not sufficient in the parents. However, I will add one extra element to that. If your scenario is a child with Huntington's disease, as got presentation, that's very early. That's a very early age to get it. So that's incredibly unlikely that the parents didn't have Huntington's disease. Because if the parents didn't have Huntington's disease, that means they didn't have enough repeats in their Huntington protein. For their child then to have really early onset Huntington's means you must have had so many more repeats. So that's telling me that that doesn't really add up. Usually if a child or an adolescent has got Huntington's, their parent would have definitely had Huntington's, if that makes sense. We can do some imaging. So the FDG PET scan can actually pick up very early disease changes. This is essentially just showing altered glucose metabolism, usually in the caudate nucleus and the putamen in the basal ganglia. I don't know how commonly that's used. Where I'm based, we don't use that so much, but maybe in America they do. But CT and MRI have got very important roles in diagnosing, but also assessing the severity of the disease, and this is mainly what we're looking at here. The late disease findings that we can see is an atrophy of the cerebrum. Okay, that's usually going to be responsible for the dementia and maybe some of the motor-like symptoms, and also then our caudate and putamen especially, and these are really what are causing the chorea movements. We can also get atrophy, especially of the caudate nuclei. That is the single most common place to get atrophy, and it's most specific for Huntington's. So if you do see a question that says a CT scan shows caudate nuclei atrophy, I would definitely keep your ears open for making a Huntington's diagnosis. And we can also get dilation of the lateral ventricles, which is linked to that caudate nuclei atrophy, and that causes the very characteristic hydrocephalus ex vacuo. So hydrocephalus ex vacuo is not really a type of hydrocephalus at all. All it is when we have a widening of the lateral ventricles due to atrophy of parts of the brain, such as the caudate, it makes the ventricles look really widened, okay? Just underneath it, you can see a normal lateral ventricle. So these are really, really widened, okay? So this looks like the patient has got hydrocephalus, but in fact they don't. Also, when you look at this CT, you can see another telltale sign. If you see here, you can see in these specific areas that the sulci and the sulci are widened. Yeah, you see this part of sulci here, that's very, very wide and very, very deep, which is telling me that there's maybe some cerebral atrophy as well. Whereas if a patient has hydrocephalus, usually the sulci are going to be almost non-existent because they're going to be compressed by the high intracranial pressure. So this is a very characteristic of hydrocephalus ex vacuo. And as you can see on the normal CT, this is where part of the caudate is. So if this caudate is heavily atrophied, that's going to widen the ventricles to appear like this. So regarding treatment now, unfortunately for Huntington's, there's no cure, okay? And disease progression can't be halted either. We should be doing genetic counselling in these patients to sort of discuss whether or not they want children, and if they want children, what's the likelihood of their children having a severe manifestation of Huntington's disease. The medical treatment that we will be giving is symptomatic and aimed at motor and associated psychiatric features. Mood disorders such as psychosis, agitation, we can give things like atypical neuroleptics. If a patient has depression and anxiety, then we should be giving our usual first line, an SSRI. When approaching treatment, it's important to consider the presence of chorea that interferes with functioning, because this is going to be helping to guide our drug selection. So, if a patient has chorea, so those motor symptoms, plus psychiatric features because of the unbalanced dopamine in the brain, then if they have these psychiatric features, then we can give atypical neuroleptics, okay? And that's going to decrease the risk of Parkinsonisms versus typical psychotics. As you know, typical antipsychotics like haloperidol, these can cause extrapyramidal effects. So I'm going to have to make sure that I'm giving atypical neuroleptics, which don't have as much of those almost Parkinsonian-like symptoms. If a patient has chorea, the motor symptoms, but they don't have any of these psychiatric conditions, of course, I don't need to give an atypical neuroleptic, okay? Instead, I can give something called a VMAT inhibitor. A VMAT inhibitor, i.e. tetrabenzene and deutetrabenzene, these are going to be inhibiting VMAT. So if I just quickly describe how that works, in your presynaptic knob, you have got vesicles inside containing, let's just say this is a dopaminergic neuron. These contain dopamine inside, ready to release to the postsynaptic cleft. We have little channels here called VMAT channels, okay? And these VMAT channels assist in filling these vesicles up with dopamine. So if I inhibit these VMAT channels, I don't fill these vesicles up with as much dopamine. So therefore, I'm going to be depleting the amount of dopamine that is going to be making it into the postsynaptic cleft. So that's going to help rebalance the dopamine excess that we see in patients with Huntington's disease. And that can help the chorea movements. Of course, when somebody has late stage Huntington's and they start to have Parkinsonian-like symptoms, we would definitely not want to give this drug because it would make it worse. Right, now moving on to Parkinson's disease and Parkinsonism. So Parkinson's disease is a neurodegenerative disorder characterized by loss of the neuromelanin-containing dopaminergic neurons in the substantia nigra, specifically the pars compacta, which is part of the basal ganglia. Pathological examination reveals round eosinophilic inclusions of alpha-synuclein, and these are called our Lewy bodies. Okay, so if you were to look at a sort of a histological slide, you would see kind of like these neurons, and then you would see little inclusions inside these neurons that will be almost purpley pink, and these are made of alpha-synuclein, and these are Lewy bodies, and they can be seen in both Parkinson's disease and Lewy body dementia. The typical presentation of Parkinson's is above 50 years old. You're very rarely going to find somebody less than 50 with Parkinson's disease. It can happen, but it's quite rare. And the risk factors are older age, family history, and a really kind of important factoid to know is that smoking is protective, because it's one of the very few diseases where smoking is actually protective. Parkinson's disease is the most common hypokinetic movement disorder and is characterized by unilateral hand tremor. So this is one of the most important things. This is called the pill rolling tremor, and it's a tremor at rest. We will discuss that more in a bit. Oscillating rigidity, and oscillating rigidity is also called cogwheel rigidity, which is one of the early signs of the motor component to Parkinson's disease. And then akinesia or bradykinesia, an absence or a loss of movement, okay? And that causes things like shuffling gait, small handwriting, etc. We can also get postural instability as well, like postural hypotension, orthostasis. These kinds of things will cause frequent falls. Parkinson's disease is an idiopathic condition, but the motor symptoms, the Parkinsonism, can occur secondary to other neurodegenerative disorders, trauma, and medications. And there is actually a lot of research into trauma, especially head trauma, and Parkinson-like symptoms. Treatment aims to do one of two things: increase dopaminergic activity and decrease cholinergic activity. So after that introduction, we're going to go into a bit more detail about this because it's quite a high yield topic and really important because so many patients get Parkinson's disease. Just a quick key fact for us to know is that gait, which is like the movement of someone when they're walking, of normal pressure hydrocephalus and Parkinson's disease are similar. A significant difference between them for diagnostic purposes is the arm swing. Okay, so in Parkinson's disease, they have this akinesia, they get this reduced arm swing. But in somebody with normal pressure hydrocephalus, they actually preserve the arm swing. Of course, for the purpose of your board exams like USMLE or whatever else you're going to be doing, there's going to be lots of other signs as well. So normal pressure hydrocephalus patients, they usually have the 3 Ws. So wacky, so they often have like neuropsychological changes, including dementia. They often have, the second W is wet, so they often have incontinence. And then wobbly, which is referring to this gait that we've just described. And the gait that we describe in normal pressure hydrocephalus is often referred to as a magnetic gait. What does that mean? That means a problem initiating gait. So it's called magnetic gait because the feet appear like they're stuck to the floor like a magnet. And that's described as magnetic gait. But all that is problem initiating movement. And it is very similar to Parkinson's, but the way that we can differentiate is by the presence of the arm swing, which is absent in Parkinson's. So now let's move on to our history and physical examination. So the preclinical stage of Parkinson's is characterized by non-motor signs such as constipation, anosmia, sleep disturbance. This is usually things like REM disorder, but it can also include restless leg syndrome and even excessive sleepiness. And by mood disorders as well, including depression, apathy, and anxiety. And these usually come before the motor symptoms, sometimes even by up to 20 years. So a lot of this preclinical stage can be explained by autonomic nervous system changes, which is why we see things like constipation and orthostasis in these patients, okay? One thing I would like to quickly note here, but we will be talking about this in another module, is the idea of differentiating Parkinson's disease from Lewy body dementia. So Lewy body dementia is where the psychotic and depressive and sleep symptoms come before the Parkinson's symptoms, okay? So when we talk about the preclinical stage of Parkinson's disease, this is usually minor depression, maybe some anxiety, but more things like constipation and sleep issues. There is a distinction between the preclinical Parkinson's and a Lewy body dementia. And we'll talk about this more in the neurodegeneration module. So after the preclinical phase, we start to get more clinical signs. So this is usually motor signs, and then more of the autonomic dysfunctions, which we do see preclinically as well, and some other neuropsychological features. So the motor signs are the most important. On onset, it's going to be unilateral, okay, with possible progression to the contralateral side eventually. It's asymmetrical, okay, it's going to be worse on one side, and the motor signs can be remembered by the mnemonic TRAPS, which we're going to be discussing here. So the tremor that our patients have, this is the cardinal sign and symptom, of Parkinson's disease. It's often a unilateral resting tremor at about 4 to 6 hertz, which improves with movement, and that's really important. Improves with movement and worsens with distraction. It's quite often described as a pill rolling quality because you'll look at a patient's hands and it looks like they're like rolling pills. I like to think of it more as like a dice rolling quality. It looks like, when you watch like someone rolling dice, to me it looks more like that. They're kind of like rolling something in their hands. Is more like a dice than a pill. And the frequency is between 4 to 6 hertz. This is a fairly low frequency, but it's not as low, for example, as the cerebellar disorders that we see, but it's not as high as things like essential tremors, which we see. So it's kind of a middle range, but it's on the lower side of the frequencies. And it's mostly in the thumb and some of the fingers, but it's very prominent in the thumb. Another motor sign is rigidity, increased resistance to passive movement that can be uniformed, i.e. lead pipe, or cogwheel, okay? And the cogwheel results in oscillating ratchet-like joint movement. Just to sort of briefly describe this, if you had a patient in front of you and you were moving their arm around, kind of like telling them to relax and moving their arm around, lead pipe rigidity would feel like you're trying to bend a pipe, okay? It's completely uniform rigidity. But the cogwheel is exactly how it sounds. It's areas of relaxation followed by interrupted stiffening, okay? And the cogwheel is more classic for Parkinson's disease. And if you ever shadow a neurologist, you'll find them doing a lot of this checking for cogwheel rigidity. Even in patients who you can't see any signs of Parkinson's visually, they will be moving the arms around and they will feel parts of unilateral cogwheeling in one of the arms. And that's often one of the first motor signs that you see in Parkinson's. Another thing is akinesia and bradykinesia. This is lacking or slowness of movement that can manifest as the narrow-based shuffling gait, which is where someone can't really walk properly, so instead they've got to shuffle around with these shortened strides, and as we've said already, they lack the arm swing. We often see small handwriting, micrographia, and hypomimia, which is essentially the masked faces, which is where they can't produce lots of facial expressions. Maybe even soft speech because they have the inability to move parts of the larynx sufficiently. And then just in terms of completing the mnemonic, we have tremor, rigidity, akinesia, postural instability, and then we have, I think it's small handwriting, and there's another S. I can't really remember it, but we've covered them. So the final one is the postural instability. This is characterized by flexed axial posture. So naturally, if you look at the posture of somebody with Parkinson's, they usually have this almost slight kyphosing of the spine, this flexed axial posture. And of course, because these patients often have orthostasis as well, this creates this easy risk of falling, okay? So always look out for that. It's a combination of the posture and the orthostasis. And then the autonomic dysfunction, I've already mentioned this before. So we have neurogenic orthostatic hypotension, I've already mentioned this. We do have increased sweating, so hyperhidrosis, and we also have the very well-known oily skin, okay? A lot of patients with Parkinson's, if you look at their skin, it looks really oily. And no one is really kind of sure of the pathophysiology of this, but one thing we do know is that Parkinson's patients produce more sebum than non-Parkinson's patients, okay? And very interestingly, people with Parkinson's disease are also at risk of a skin disorder called seborrheic dermatitis. And if you have a chance now, I'd quickly search that up on the internet. It's related to, I think, tinea versicolor, which obviously feeds on sebum. So it makes sense that patients with Parkinson's who have lots of sebum and oily skin are prone to getting this bacterial infection that causes seborrheic dermatitis. Constipation, that's an autonomic nervous system problem. Sexual dysfunction, exactly the same. Urinary urgency and even dysphagia. Okay, so normal ANS problems. And then finally, the neuropsychiatric problems, dementia, okay? We do have in advanced disease, dementia. If you have the alpha-synuclein deposits, these deposits within the basal ganglia, this causes the movement symptoms. If you get them in the cerebrum, that's what causes the dementia, okay? Aside from dementia, we can also have executive dysfunction, visuospatial dysfunction, visual hallucinations, delusions, sleep disorders. A lot of the sleep disorders can mimic a lot of the REM disorders, like things like narcolepsy. Aside from REM, also narcolepsy, So sleep attacks, vivid dreams, sleep fragmentations, and then also things like depression, anxiety, apathy, and anosmia as well. And here's the mnemonic that we had just mentioned. So the TRAPS is for the mainly for the motor symptoms. So we've discussed tremor, pill rolling, cogwheeling, akinesia, postural instability, shuffling gait, and then the small handwriting. So how do we actually diagnose Parkinson's? So it's a clinical diagnosis mostly. You're looking for the symptoms of TRAPS, and but the kind of key element here is that you need to rule out other conditions that may be causing the TRAPS symptoms, okay? Clinical suspicion for alternative causes increase when there is a lack of response to levodopa and some of the following signs, okay? So if you have a patient, they have signs of TRAPS, you give levodopa and they don't improve, I've got to be thinking this patient may have TRAPS signs and symptoms, Parkinsonisms, secondary to another disorder, okay? Parkinson's disease, if you give a patient with Parkinson's disease levodopa, their symptoms will improve 100%, okay, if they're newly diagnosed. So if it doesn't improve, this should raise some alarm bells that it's a secondary Parkinsonism. So some of the kind of other disorders that, you've kind of got to rule out before making a diagnosis of Parkinson's, all of these disorders can cause the TRAPS signs and symptoms. I'm going to briefly go over them. They're not so high yield, but I'm going to go over them. So we have got something called multiple systems atrophy, which is MSA. We've got two different types. So the MSA-P is the Parkinson's type, and then the MSA-C is the cerebellar type. Both of these conditions can have TRAPS symptoms, so like tremor, rigidity, akinesia, etc. The MSA-P is also called Shy-Drager syndrome, and these patients have Parkinson's-like symptoms, but they have a very heavy autonomic nervous system component. So these patients have a huge amount of orthostatic hypotension, lots of maybe constipation problems, lots of hyperhidrosis problems. It becomes very predominant in the ANS department. And then the MSA cerebellar type is due to more cerebellar ataxia. These patients don't have as much Parkinsonisms, they can have some, but it's more cerebellar-like problems. So dysmetria, you understand, lack of coordination, gait, etc. Another really interesting disease is some of the ocular motor deficits that we can get. So there is a condition called progressive supranuclear palsy, also called PSP, and this is essentially where we have neurodegeneration of like the supranuclear area. And the supranuclear area does vertical gaze, okay? So it does like the up and the down of the eyes, not the side to side, but the up and the down. So patients who have got Lewy bodies kind of depositing in the supranuclear area of the brain, they can get the supranuclear palsy, and that's going to cause a problem with gaze palsy. People with Parkinson's can get sort of problems with their vertical gaze, but if a patient has got specifically progressive supranuclear palsy separately, that is a separate condition, a separate diagnosis, let's say. We also have impaired cognition, dystonia, sensory deficits, myoclonus. This can be due to more specifically corticobasal degeneration. And also certain patients on certain drugs can also get some of the Parkinson-like symptoms. Always look out for typical antipsychotics, okay? Haloperidol, fluphenazine, these sorts of these sorts of drugs. Also look out for antiemetics, the dopamine antagonist antiemetics such as metoclopramide, and then also vesicular dopamine depleters such as tetrabenzene, benazine, and rezapine. And some CCBs can also cause it as well. These CCBs are not very commonly used, but they are responsible for causing Parkinson's-like symptoms. If you notice a lot of the medications here, they are dopamine antagonists, right? I mean, the typical antipsychotics, very heavily dopamine antagonists. The antiemetics such as metoclopramide, these are dopamine antagonists. So you can see, if I'm antagonizing dopamine, this is going to prevent dopamine from working in sort of the in the basal ganglia, and that can cause Parkinson-like symptoms. I think you should all be fairly familiar with that concept. Some infrequent causes are the atypical antipsychotics. As we know, atypical antipsychotics don't cause as many movement problems as the typical antipsychotics, such as clozapine, olanzapine, quetiapine. So if a patient comes to you with Parkinson's disease and they have psychotic problems, we can give quetiapine, okay? And the mnemonic that they have, or the way that first aid is given to remember that, is that it's quiet. So it's used for Parkinson's disease psychosis. Lithium can occasionally cause Parkinson's-like symptoms, and some antiepileptics like valproate and phenytoin. Some antiarrhythmics like amiodarone can cause it. And then also this drug called MPTP, which is an illegal recreational drug. It was used a lot, I think, in the 80s or the 90s. It's not used much now, but it destroys the dopaminergic neurons in the substantia nigra and can cause iatrogenic, not really iatrogenic, but medication and drug-induced Parkinson's. Of course, patients with Wilson's disease and hemochromatosis, they can have Parkinson's-like movement problems, especially Wilson's disease, but of course that's a separate diagnosis. And then dementia. This is really important, and we're going to be discussing this in the neurodegeneration module. People with Lewy body dementia, it's a separate diagnosis to Parkinson's disease, and we'll discuss that in a separate video. So just a quick key fact, treatment of Parkinson's disease is based on an elevation of dopaminergic activity and the relative decrease in cholinergic activity as these circuits become unbalanced with a loss of dopaminergic neurons in the substantia nigra pars compacta. Dopamine activates the direct pathway and inhibits the indirect pathway, which is going to be promoting movement. Acetylcholine inhibits the direct pathway and activates the indirect pathway, essentially inhibiting movement. This is a huge oversimplification, but if you're sitting step 1, I would make sure you know the direct and indirect pathway and specifically how these work, but it's not so important for step 2. Moving now on to treatment. So the general guidelines for treatment is basically what we've just said already, with the loss of dopaminergic neurons in the pars compacta, cholinergic circuits operate relatively unopposed, so we have a huge increase in the cholinergic activity, and treatment is just there to restore the balance by either increasing dopaminergic activity or decreasing cholinergic activity. Okay? One thing that you should keep in mind when a patient is on medications for Parkinson's disease is that they're going to have an increase in dopaminergic activity. Okay, so you've got to know the side effects of doing something like that. So the side effects of a high dopamine activity is things like nausea and vomiting, orthostatic hypotension, sleepiness, dyskinesia, confusions and hallucinations. Okay, so look out for that in these patients. Initial treatment, if possible, should involve agents other than levodopa-carbidopa, especially if the patient's young. And that's because when I give dopamine, levodopa-carbidopa, that's going to actually, reduce its efficacy in the long run. And that's going to increase this on-off phenomena that we find very hard when battling the treatment of Parkinson's disease. So if a patient's young, if they've got mild disease, generally speaking, we don't give levodopa-carbidopa first, because we want to save that for when they're a little bit older, okay? So just really briefly, I'm going to talk about where most of the medications work. This is more of a step one concept, but it's really important to know anyway. So the kind of main drug that we do use is levodopa. So levodopa is given, it can then cross the blood-brain barrier, it goes into the presynaptic neurons of dopaminergic neurons, and that just provides essentially dopamine, more dopamine, okay, so it can relieve the symptoms of Parkinson's. It's usually given with a drug called carbidopa, okay, and carbidopa inhibits the dopamine decarboxylase enzyme, which breaks down dopa into dopamine in the circulation. So if dopa is broken down into dopamine in the circulation, this causes lots of side effects like orthostatic hypotension. And it also decreases the bioavailability of dopa to get into the blood-brain barrier. So if I give carbidopa, that's going to prevent the peripheral breakdown, prevent these side effects, and increase the amount of dopa going into the brain. We can also have COMT inhibitors. These are the capones, so entacapone, tolcapone. These can inhibit the breakdown of dopa both in the circulation and in the brain. We also have got monoamine oxidase inhibitors. These are the gilines, so selagalene and rasagalene. These are preventing, again, breakdown of dopa, but they prevent breakdown of dopa within the synapse specifically. We also have amantadine, which increases dopamine availability. And then we have direct dopamine agonists, okay? Pramipexole, bromocriptine, for example, and these will just be acting on the dopamine receptors. So let's talk about the more step 2 CK concepts. If a patient comes to us with mild symptoms and a minimal impact on daily living, i.e. they're not struggling with their Parkinson's symptoms to the point that they are struggling with their day-to-day living, the initial therapy should not be dopa, carbidopa. It shouldn't be, okay? We want to start instead with a monoamine oxidase inhibitor, so selagalene, rasagalene, for example. That's going to essentially decrease the breakdown of dopa and dopamine in the CNS, and therefore increase endogenous dopamine, all right? A very important fact to know about whenever you give somebody a monoamine oxidase inhibitor is that they should not be eating foods that are rich in tyramine. So tyramine is usually found in things like cheese, but also chocolate as well. I think it's found in some alcohols as well. And monoamine oxidase, the enzyme, also exists in our gut. And that essentially breaks down tyramine in the gut. So if I give a monoamine oxidase inhibitor, that prevents the breakdown of tyramine in the gut, allowing for more absorption of tyramine. And tyramine causes hypertension because it increases norepinephrine release. So if I, all of a sudden, I'm on a monoamine oxidase inhibitor and then I have a huge cheese board with lots of alcohol, lots of booze, this is going to increase the tyramine in my gut, I'm not going to have any way to break it down in the gut, so I'm going to absorb lots of tyramine, and that's going to cause potentially a hypertensive crisis. One thing to note, we also give monoamine oxidase inhibitors in depression. Okay, these are the monoamine oxidase A inhibitors, and these are more likely to cause this hypertensive crisis. Okay. If somebody comes to you with Parkinson's disease, they don't have an akinesia, bradykinesia predominant Parkinson's, but instead have a tremor dominant Parkinson's, we like to give them M1 muscarinic antagonists first. This is usually benztropine, trihexyphenidyl. We usually give these, okay? These are also the same medications that we give to counteract the side effects of dopamine antagonists. So, if somebody's taking like haloperidol and they all of a sudden start to get like Parkinson-like signs, those extrapyramidal signs, we usually give M1 muscarinic antagonists. Now, let's talk about if a patient's got mild to moderate symptoms, but there is an impact on daily living. The best therapy we can actually give this time is a dopamine agonist, okay? We're now giving something that is going to act directly on the receptors. It's not increasing endogenous dopamine availability like the MOA inhibitors. It's going to be actually providing more stimulation of the dopamine receptors. So I kind of see it as like a step up. And this is like your pramipexole, your opinarole, but this is useful also in young patients as well, okay? So if somebody's got, as I said, mild to moderate symptoms, not impacting daily living, monoamine oxidase B inhibitors. If somebody's got mild to moderate symptoms, but there is a bit of impact on daily living, or if they're younger than 65 years old, I'm going to go to my dopamine receptor agonists instead. Now, let's talk if the patient has moderate to severe symptoms with a significant impact on daily living. The best and most effective therapy now is the levodopa-carbidopa. It's by far the most effective drug, so I've got to reserve that for patients who have got the severe symptoms. Typically, it is also a first-line treatment for patients above 65 years old, and this concept here I've already described above. This is just describing how carbidopa blocks the peripheral conversion of dopa in the circulation. Excuse me. One thing that we do have to take into consideration is the on-off phenomena. So when somebody's had long-term use of dopa, this decreases the natural endogenous dopamine. So patients become dependent on dopa, on L-dopa. So we have an on period, which is where the patient has really good movement, but they even have a bit of dyskinesia, so some involuntary movement. And then they have this off period, which is where they have severe brady and even akinesia. And this is an on-off phenomena, and it's the main limitation of giving levodopa-carbidopa. And that's why we don't like to give it in somebody with minor symptoms or in a really young patient, because then by the time they get older, they're going to have really bad on-off symptoms. So alongside our levodopa-carbidopa, we can give the boosting agents, okay? COMT inhibitors, monoamine oxidase B inhibitors, just to increase the amount of endogenous and available dopamine to decrease the off periods. So if you have a question, somebody's on levodopa-carbidopa, they describe these on-off periods, and they say, what medication would you give? We can say, I would give entacapone, for example, or I would give selagalene, for example. Okay? Good. Now, surgery. Surgery is not that commonly given, and it's usually reserved for patients who are refractory to medical treatment and to those who develop severe severe disease or are younger than 40 years old, okay? And the type of surgery we do is we do an implantation of a deep brain stimulator that is essentially going to be suppressing the neural activity of the subthalamic nucleus and the globus pallidus internus. I'm not going to go into the details of the direct and indirect pathway of the basal ganglia, but just so you know, the globus pallidus, internus, and the subthalamic nucleus, these are big contributors to the indirect pathway. And the indirect pathway generally inhibits movement. So if I have a deep brain stimulator which is going to inhibit these structures, I'm going to be decreasing the indirect pathway and thus increasing movement. Okay? So that's just something that can be done for patients who are refractory or young or very severe with their symptoms. Just a caution with specific drugs. So any drugs that have got anti-dopaminergic activity, such as metoclopramide, prochlorperazine, or some of the typical antipsychotics, we should try and avoid in these patients because it's going to worsen the motor symptoms. I've already mentioned we can give quietapine, or the quiet one, which is an antipsychotic that is got very little motor side effects. Also, something called pimavanserin is an antipsychotic that inhibits 5-HT, aka serotonin, not dopamine, and that again is going to have less motor side effects. I'm not going to go over the anticholinergic side effects, but do bear in mind if your patient with Parkinson's is taking anticholinergic drugs, they can have an anticholinergic toxidrome, so always look out for that in questions. And then just some key facts as well. So the pathology that happens in things like neurodegeneration will determine the phenotype. So in Parkinson's disease, we have a loss of the dopaminergic neurons in the basal ganglia. Because they're in the basal ganglia, we're going to be getting movement symptoms, such as our extrapyramidal motor symptoms, tremor, akinesia, bradykinesia, etc. In Alzheimer's disease, we lose mainly cholinergic neurons in the cortex and the subcortex, and that is what causes dementia. ALS, which we will discuss next, is the loss of the upper and lower motor neurons. So we get upper and lower motor neuron signs, right? So like hyperreflexia, while at the same time having fasciculations. But there's going to be no sensory changes and rarely dementia. Myasthenia gravis, we know this is a loss of the acetylcholine receptor function, so the patients get fatigable muscles. And then Huntington's disease, which we've already mentioned, is a loss of the GABA and acetylcholine activity, usually in the cerebrum, but more seen in the striatum. And that causes an unbalanced dopamine activity, which causes more movement and memory and mood findings. Okay, just a quick key fact before we start ALS. If a 55-year-old man presents with slowly progressive weakness with increased reflexes in his left upper extremity and later in his right thigh with upper motor neuron signs like hyperreflexia and maybe a positive Babinski, associated with fasciculations and atrophy, but without bladder disturbance and a normal cervical MRI, this is a key finding for ALS. Okay, and we're going to be discussing that now. So let's discuss the details of ALS. ALS in the US is called Lou Gehrig disease, whereas in the UK we call it motor neuron disease, but everybody calls it ALS generally. It's a chronic progressive disease characterized by loss of the upper and lower motor neurons. And if you know that, that can describe most of the signs and symptoms. It's often sporadic, 90% of cases are sporadic, but it can also be genetic as well. Age, family history, cigarette smoking are all risk factors. ALS has an unrelenting course and almost always is progressive and leads to respiratory failure and death. Usually within 5 years of diagnosis this will be seen, but there are some cases, obviously like Stephen Hawking, who had ALS for considerably longer than 5 years, but most patients unfortunately do die within 5 years. Men are more commonly affected than women, and the onset range is huge, between 40 years old and 80 years old. So let's talk a little bit now about the history. So it usually presents with an asymmetric, slowly progressive weakness, we're talking over months to years, affecting arms, legs, diaphragm, lower cranial nerves, okay? And most patients with ALS actually have hand symptoms first, maybe weakness of hands, maybe some weakness of part of the arms, but it's often in the hands. That's usually the presenting complaint. Initial presentation, an asymmetric extremity weakness, but it can be fasciculations as well. So we're going to be seeing upper motor neuron signs and lower motor neuron signs. So just a quick kind of like recap for you. Upper motor neuron signs, you're usually looking at hyperreflexia, an increased tone, clasp knife rigidity, Babinski sign. Whereas lower motor neuron signs, you're usually looking at fasciculations, flaccid paralysis, negative Babinski, and even atrophy of the muscle. Okay. Sensation, eye movement, and sphincter tone will be spared. Yeah, people with ALS, it's almost an exclusive motor condition. You're not going to have any sensory loss at all. Emotional liability can also be seen as well, and I'm going to discuss that in a little bit more detail. And differences in symptom onset and spread cause is variable from patient to patient, okay? About 20% of patients have bulbar onset ALS, okay? So aside from what I mentioned, that the hands are very common presenting complaint, bulbar symptoms can also be very common presenting complaint as well, which means patients usually present with speech and swallowing condition symptoms, such as dysarthria, dysphagia, and a loss of tongue mobility. And patients can also have a pseudobulbar affect as well. The pseudobulbar affect is, just before I go into that, let's discuss what's bulbar and what's pseudobulbar. So bulbar is essentially the lower motor neuron signs of the cranial nerves. Okay, so it is an actual weakness, a flaccid paralysis of the muscles in the oropharyngeal area, the cranial nerves. Pseudobulbar is exactly the same, but the upper motor neuron effect of it. So a patient has dysarthria, dysphagia, unable to speak properly, unable to chew. That could be bulbar or pseudobulbar. But then let's just say I try to elicit the gag reflex. If the gag reflex is absent, that's a bulbar sign because it's a sign that it's a lower motor neuron. But if the patient has got a really exaggerated gag reflex, then this is a sign that it's pseudobulbar. It's an upper motor neuron sign. Okay, so that's the difference between bulbar and pseudobulbar. But the pseudobulbar affect is essentially a disconnect between the brain and the functioning of like the oropharynx. So patients may all of a sudden start laughing or crying. This is not because these patients have got psychiatric problems. It's nothing to do with them actually feeling happy or sad, but because there's this disconnect between the cerebrum and the movements of the mouth and the movements of the face, you can all of a sudden start laughing and crying even though you're not meaning to. And that's also called the pseudobulbar affect, and it's linked to those upper motor neuron pseudobulbar palsy. So how do we diagnose ALS? So ALS is usually diagnosed clinically, okay, but it follows these specific criteria. You're looking for a progressive motor dysfunction preceded by a previously normal motor function. You should have evidence of both upper motor neuron and lower motor neuron involvement of one body segment or evidence of lower motor neuron involvement of two body segments. Investigations should be done to exclude other diseases that could explain these symptoms. An EMG and nerve conduction studies should be done, and they will reveal denervation and spontaneous action. So spontaneous action potentials, these are called fibrillation potentials. Don't be fooled. These are signs of lower motor neuron disorders, okay? I know you think spontaneous action potential sounds like an upper motor neuron thing, but it's kind of the same as like a fasciculation. It's actually a lower motor neuron problem. And then such studies are principally performed to exclude other demyelinating motor neuropathies, maybe something like Guillain-Barré syndrome, or maybe other disorders like even MS as well. CT and MRI of the cervical spine should be done, and the answer is why. Why? Because it has very similar symptoms to my cervical spondylosis. If I'm compressing the cervical spine, this will create upper motor neuron signs and lower motor neuron signs, okay? So we need to do a CT and an MRI of the cervical spine to exclude a cervical spondylosis. just a general rule of thumb, if somebody has a cervical spondylosis, are they going to get cranial nerve signs, any bulbar or pseudobulbar signs? No, because a cervical spondylosis is compressing the spinal cord below the cranial nerves. The cranial nerves are within the brain, within the kind of cavity of the skull. So if you see any kind of cranial nerve signs, that points towards ALS. But doing a CT and MRI is especially helpful in those who don't have bulbar involvement, because that means I can't tell so easily whether it's a cervical spondylosis that wouldn't have cranial nerve symptoms and my ALS, which would normally have it. So if the ALS doesn't have those bulbar symptoms, a CT and MRI of the cervical spine is very helpful. Just a quick key fact, bulbar involvement of the tongue, like cranial nerve 12 involvement, and oropharyngeal muscles like cranial nerve 9, your oropharyngeal stuff, suggests pathology above the foramen magnum, i.e. within the skull, and this helps distinguish ALS from the cervical spondylosis. This is exactly what I've been saying. So what's the treatment of ALS? Unfortunately, there is no cure. We're going to be doing supportive measures and patient education, okay? If somebody has really severe spasticity from upper motor neuron signs, I can give baclofen. I should also be doing regular serial pulmonary assessments, especially at the beginning of diagnosis, because patients with ALS commonly die from respiratory failure. This is because the diaphragm, or the motor neurons supplying the diaphragm, become damaged, and the patient can die of respiratory distress. If somebody has got signs of respiratory insufficiency, the first line therapy is non-invasive positive pressure ventilation. That could be your CPAP, BiPAP, APAP, any of the PAPs, essentially. And that's really, really high yield in step 2 to recognize that. Supportive measures and patient education. So I can give the famous drug called riluzole, and riluzole essentially is going to be stopping the glutamate-induced exocytotoxicity. This is only really going to prolong life and improve symptoms by 2 to 3 months, so it's really not a blockbuster drug, but it is used in clinic. And a more commonly used drug, a more novel drug is edaravone. Okay, edaravone is new and it's used in advanced ALS, but the main one that they like to kind of quiz you on is riluzole, and you can remember that by RILOU, Zol. Okay, I've just spelled that slightly wrong, and this in the name can remind you of Lou Gehrig, which is I think the baseball player who died of ALS, which is the other name. So it's like riluzole, and that can remind you that it's for ALS. Excellent. So moving on now to restless leg syndrome. Restless leg syndrome is a common disorder characterized by leg diastasis, which is like an abnormal sensation, like a crawling or an itching feel, and an irresistible urge to move the legs while at rest, okay, especially when lying flat. These symptoms are partially relieved with movement, and they typically occur with inactivity, classically in the evening time or at bedtime and while sleeping. So the partner may even report in the question stem that that their partner kicks them at night. In terms of causes, it can be primary, so no specific cause, or it can be secondary, and this is usually occurring in the midst of an iron deficiency anemia, okay? And that's because the misuse of iron in the CNS impairs CNS dopamine pathways. Uremia, so patients who have got end-stage renal disease, chronic kidney disease, they also get restless leg syndrome, and also cancers, especially colon cancer as well. Pregnancy, diabetes, MS, Parkinson's disease, and some drugs including antidepressants and metoclopramide. These can also cause restless leg syndrome. Diabetes, it's often associated with the peripheral neuropathy and the neuropathic pain that they get with it. Your diagnosis, completely clinical, okay? You're going to be ruling out other kind of potential causes, but you should always do a serum iron study because the iron deficiency anemia is very commonly associated with restless leg syndrome. How do we treat this patient? So we usually treat this patient with iron supplementation if they had low ferritin, okay, with deficient iron. If the symptoms are sort of mild and intermittent, we can just do supportive therapy like a leg massage, heating pads, exercise, and avoid any aggravating symptoms. But if the symptoms are more persistent and maybe more severe, then we can start to give pharmacotherapy. So we can give pramipexole or ropinirole. These are the dopamine agonists. And then for some patients, they may benefit from neuropathic pain agents like gabapentin or pregabalin. Just a quick key fact, lesions in the superior colliculus can result in something called Paranu syndrome, which is a paralysis of conjugate vertical gaze. So if you look at the brainstem, or the midbrain, shall I say, we have the superior colliculus and the inferior colliculus. So the superior colliculus are two components of the posterior dorsal midbrain, and then we have the inferior colliculus as well. The inferior colliculus it's based usually on hearing and the vestibular system. So they are usually going to be coordinating things like hearing and the vestibular kind of network. The superior colliculus, though, is going to be controlling mainly vertical gaze. So if you have any lesions in the superior colliculus, this can cause something called Paranu syndrome. And Paranu syndrome is where patients have a paralysis of vertical gaze. They also have usually other symptoms, and these symptoms can include eyelid retraction, and they also have the inability of the pupil to myose, so constrict, during the light reflex, but yet they keep their pupil constriction during accommodation. And if you are familiar with neurosyphilis patients have exactly the same sign, and that's called the pseudo-Argyll-Robertson pupil, where it can accommodate to, where it can constrict to accommodation, but not to light. And patients with Paranu syndrome have exactly the same. And when you're talking about Paranu syndrome, you're usually talking about a tumor located in the posterior midbrain. And this is usually a germinoma, okay? It's also called, it's called a germinoma. And these are usually found near the pineal gland, okay? So if you see a germinoma, they also call them, I think, pinealomas. But if you see any patients with these quite often compress the superior colliculus and they can cause Paranu syndrome. Good, now we're going to move on to tremors. So a tremor is an involuntary rhythmic oscillatory movement of one or more body part, and tremors can represent a diverse set of movement disorders. I'm going to quickly go through the algorithm, but we will be going through each tremor and how to distinguish between them. So when a patient has a tremor, the first thing I need to be asking is timing. Does the tremor occur at rest, or does it occur with movement? If it occurs with rest, this is called a resting tremor, and this is basically pathognomic for a Parkinson tremor. If the timing means that the tremor is worse with some kind of action and is relieved by rest, this is called an action tremor. We have physiological tremors, essential tremors, and intention tremors. We're going to be discussing them separately. Physiological tremors are tremors associated with an increase in the sympathetic nervous system. So all of you watching this will have had a physiological tremor at some point. Maybe you got really scared before an exam, maybe you drank too much coffee, or even patients who have hyperthyroidism or pheochromocytoma, they're going to have a physiological tremor. Whereas the intention tremor is usually associated with cerebellar disturbance, okay? And then essential tremor is an actual condition, and we're going to discuss these in more detail. So, as I've already said, my resting tremor, this is where the tremor occurs without movement, so it's at rest. It's often described as a pill rolling tremor, which happens at the 4 to 6 hertz. We've discussed this already. A Parkinsonian tremor can occur with Parkinson's disease or neuroleptics, normally things like haloperidol, and it improves with movement, okay? And the treatment for this is usually going to be an anticholinergic agent or a dopaminergic agent. Now my action tremors, we have postural tremors, which is the physiological tremor, and then the kinetic tremors. So a postural tremor is exactly what it says. The tremor is worse when you're holding it up against gravity, but not when you have actual purposeful movement, which is the kinetic tremor. So this is the physiological tremor. It's an incredibly fine tremor, okay? These patients have got a 10 to 12 hertz tremor. That's where your hands are going to be tremoring really, really fast. And this is due to an increase in the sympathetic activity, and it will improve when we decrease the sympathetic activity, and the treatment will be treating the cause, treating the anxiety, maybe treating hypoglycemic attacks, which can also have tremor. So it's just treating the underlying cause. The kinetic tremors, unlike postural tremors, these are actually occurring with any voluntary movement, okay? So not just lifting up against gravity, but actually doing voluntary movement. We have two different types. We have the essential tremor and the intention tremor. The essential tremor is, again, a fairly fine tremor. It's about 6 to 12 hertz. It's going to be bilateral, and it worsens usually when you have an outstretched hand or when you point towards something, okay? It's actually an autosomal dominant condition. It's going to be familial. So you're going to have a patient who's got an essential tremor, and their mum had it, and their sister has it, okay? A lot of these patients self-medicate with alcohol, okay? And that's quite often going to be in your question stem. They like to mention that. But the actual pharmacotherapy that we give is propranolol. We can also give primidone, but propranolol is the first line treatment for essential tremor. In contrast to intention tremor is an asymmetrical but coarse tremor. What does a coarse tremor mean? That means a very low frequency, okay? It's going to be not that fast, okay? And this is usually seen in cerebellar diseases, okay? And more commonly, if you look at the cerebellum, you obviously have like the vermis of the cerebellum, and then you have like the hemispheres of the cerebellum. The intention tremor usually happens when you have lesions of the hemispheres of the cerebellum, not so much the vermis, okay? And you're going to ask the patient to have their finger on their nose, and then you're going to ask them to point their finger to your hand. And as it approaches the target, you're going to get zigzag motions. Also, if you ask the patient to have their hands, their arms out with their palms facing down, you ask them to close their eyes, you push down their hand and ask them to bring it up to the same position, they have a rebound. And this is called a rebound tremor. And this is also seen in Parkinson's, okay? It's also called dysmetria, this overshooting. Unfortunately, there's nothing really that makes it better other than treating the underlying cerebellar disease. And then aside from those tremors, we do have something called a flapping tremor or an asterixis. This is variable in frequency and amplitude, and it's usually not so symmetrical. And this is where you ask a patient to have their hands out and then lift their palms facing up, and you'll find that their hands start to flap. And this is also called an asterixis, and it's associated with an elevated level of ammonia, usually seen in hepatic encephalopathy. And it's also referred to as the liver flap. The treatment will be to decrease ammonia, and if you remember from GI, we discussed this. We give lactulose and rifampin, and that can help alleviate the asterixis as well. And any underlying liver disease, but also renal disease, will be responsible. And then finally, last but not least, we do have a functional psychogenic tremor, and this is essentially more of a psychological problem. But it's multiple tremor types in one. It's going to be abrupt onset with no specific underlying neurological cause. Maybe the patient has a history of trauma, and maybe this is actually part of a conversion disorder instead. So the patient hasn't got like Munchausen. They're not making it up, but it doesn't really fit in line with a neurological disorder, okay? And if you actually distract the patient, the tremor goes away. Okay, and this patient is going to be indicated for psychotherapy. Great. Now, last but not least, we're going to talk about Wilson's disease. It's also called hepatolenticular degeneration. That's like the neurological consequence of Wilson's disease. But Wilson's disease we do discuss in the GI unit when we discuss liver diseases, but it does cause quite a few neurological symptoms, so we're going to discuss that here. Wilson's is an autosomal recessive disorder, and it's an accumulation of copper in various different tissues, and it's due to a mutation in the ATP7B gene. The ATP7B gene codes for a protein that does two things: excretes copper into the bile and also binds copper to make ceruloplasmin. Okay? So essentially, if we don't have the ability to excrete copper and make ceruloplasmin, we have lots of free copper, and that's going to deposit in things like the liver, causing sort of liver disease, the brain, causing hepatolenticular degeneration, even the kidneys, and then very famously the cornea as well. So what are the clinical features of Wilson's? Patients usually develop liver disease before the age of 40. This can present with hepatitis, jaundice, ascites, and even cirrhosis in the late stages. And we do have the neurological diseases as well. So we have dysarthria, dystonia, tremor, and even Parkinsonisms, okay, as well. It may manifest early in the course of the disease, or it may come later. Here they've mentioned it as early, but there are patients that I have seen that have had their neurological diseases very mildly and very late on in the disease. Patients can also get copper deposition in the proximal convoluted tubule of the kidney, and that can lead to Fanconi syndrome. So do look out for glucosuria, amino aciduria, hyperuricemia, and even like the type 2 renal tubular acidosis, the aka proximal renal tubular acidosis. Of course, we do have the very famous Kaiser-Fleischer rings, that is the copper deposition in the Descemet's membrane. And one thing I really want to stress is that the Descemet's membrane is not the iris, it's the cornea. And Step 1 love to test you on this because they know most students think that it's the copper deposition in the iris. It's not, it's in the cornea. And that actually came up in an examination, not USMLE, but it came up in another exam that I've done. So how do we diagnose patients with Wilson's disease? The initial test, given that we have a suspicion for Wilson's disease, will be my LFTs. Why? Because I'm going to be looking for an elevation of AST, my ALT, and even a complete blood count to look for some other things like anemia. My diagnostic test is going to be a mixture of things. It's going to be checking the ceruloplasmin level, which is going to be low. Remember, I said that the ATP7B gene codes for a protein that makes ceruloplasmin, so of course in this case it's going to be low, and an elevated urinary copper level as well. If the patient has got neurological signs, I will also do a slit lamp test, and I will see Kaiser-Fleischer rings as well. And this combination will confirm the diagnosis. The most specific test will obviously be a liver biopsy, okay? Because with the liver biopsy, I can literally see copper buildup within like hepatocyte cells and within the surrounding structures. But this is very invasive and it's not required for the diagnosis. And then finally, treatment. Treatment is penicillamine. This is a chelator of copper. There's also another chelator called trientine, and trientine has got fewer side effects than penicillamine. Oral zinc can also be considered as an alternative, and I need to be educating the patient on a diet low in copper. Copper is seen quite predominantly in things like mushrooms, chocolate, nuts, dried fruit, liver itself, and shellfish. So we would advise the patient to cut down on that. And that is everything for the movement disorders in neurology. I hope that was helpful, and that was a long video, so well done if you stuck with it.